Assessment and treatment of cardiomyopathy and its correlation to sleep. The assessment of cardiomyopathy involves identifying not only structural and functional cardiac abnormalities, but also assessing how the cardiac changes interact with sleep physiology. The evaluation begins with a thorough history and physical exam from the patient that focuses on symptoms such as dyspnea, fatigue, orthopnea, paroxysmal nocturnal dyspnea, palpitations, and sleep disturbances. Special attention needs to be given to complaints from the patient of waking up, gasping for air, loud snoring, excessive daytime sleepiness, or frequent nighttime awakenings, as these may point to comorbid sleep-disordered breathing. A key tool used in assessing cardiomyopathy is the echocardiogram. This focuses on real-time imaging of cardiac chamber sizes, wall thickness, ejection fraction, diastolic function, and any outflow tract obstruction or valvular abnormalities. In dilated cardiomyopathy, echocardiography typically reveals an enlarged left ventricle with reduced systolic function. In hypertrophic cardiomyopathy, the walls, particularly the interventricular septum, appear abnormally thickened, and Doppler studies may show dynamic obstruction. Restrictive cardiomyopathy shows impaired ventricular filling with normal or near normal systolic function. These structural findings not only confirm the diagnosis, but also explains the hemodynamic changes that contributes to symptoms like PND or orthopnea, both of which become prominent during sleep due to fluid redistribution and reduced respiratory drive. Now, when we're assessing how cardiomyopathy interacts with sleep, we use a sleep study, which is also polysomnography. This will be overnight, usually, and the overnight test monitors respiratory patterns, oxygen saturations, heart rate, and sleep architecture. Many patients with cardiomyopathy are found to have obstructive sleep apnea or central sleep apnea. OSA is marked by repetitive airway collapse and desaturations, which worsens that afterload and contributes to sympathetic overactivity. Often associated with advanced heart failure, is typified by Cheyne-Stokes respiration and a crescendo-decrescendo breathing pattern caused by instability in carbon dioxide regulation due to prolonged circulation time and impaired chemoreceptor sensitivity. Identifying these conditions through the polysomnography is critical because they directly impact cardiac function and increase the risk of arrhythmias, fluid retention, and sudden cardiac death. Once cardiomyopathy is diagnosed, the treatment focuses on optimizing cardiac function while addressing the sleep-related complications. In dilated cardiomyopathy, first-line medications include ACE inhibitors like lisinopril, angiotensin receptor blockers to reduce afterload and myocardial stress, beta blockers like metoprolol succinate are added to control the heart rate, reduce arrhythmias, and improve ventricular filling. Diuretics relieve that fluid overload and reduce symptoms of orthopnea and PND, which directly improves sleep quality. In patients with advanced disease, aldosterone antagonists like spironolactone or eplerenone will help reduce and remodel that fluid retention. In hypertrophic cardiomyopathy, treatment centers on managing obstruction and diastolic dysfunction. Beta blockers or non-dihydrodyne calcium blockers will help decrease the heart rate and enhance diastolic filling. If obstruction is severe and symptomatic, despite the medical therapy, septal reduction procedures such as surgical myectomy or alcohol septal ablation may be indicated. When sleep apnea is identified in a patient with cardiomyopathy, positive airway pressure therapy becomes a cornerstone for that treatment. For patients with OSA, continuous positive airway pressure, like CPAP, prevents the upper airway closure during sleep, improving oxygenation, reducing nighttime sympathetic surges, and lowering that blood pressure. CPAP therapy has been shown to improve left ventricular ejection fraction, reduce hospital readmissions, and improve quality of life in heart failure patients with OSA. For those with CSA or Cheyne-Stokes respiration, treatments is more nuanced, I guess you can say. ASV was once commonly used but has shown increased mortality in certain patients with reduced ejection fraction. In selected cases, options such as phrenic nerve stimulation or supplemental oxygen may be considered, but careful evaluation is necessary. Beyond device and pharmacologic therapy, lifestyle modifications can be made for both cardiomyopathy and sleep apnea management. Patients are advised to follow a low-sodium diet, maintain fluid restrictions, and engage in regular supervised exercise. Weight loss and alcohol avoidance are particularly important in sleep apnea management and can reduce the severity of apneic events. In some cases, implantable cardioverter defibrillators are indicated for primary prevention in patients with low ejection fraction or high arrhythmia risk, especially those experiencing nocturnal ventricular arrhythmias triggered by sleep-related hypoxia.